Hi all, welcome to Dr. Whiteboard Talks. Today's topic is valvular heart disease and murmurs. In this topic, I will be covering those general brief idea of valvular heart diseases, their etiology, most common etiologies, and a little about the functional anatomy of the heart valves, and I'll be moving towards the murmurs. The focus of this topic is not to elaborate the most important valvular heart diseases, but just giving an idea how to approach MCQ questions and solve the clinical cases as well as the OPD cases that you get in your day-to-day life, that how to differentiate between those two different murmurs and their clinical examination, as well as how to make a diagnosis. So mostly this will help for those people who prepare for prometric exams, or those who prepare for some competitive exam or outside country exam like Mrcp or UK exams. Starting with the topic, heart valves. So valvular heart disease means that we should know a functional anatomy of heart valves. So a functional anatomy means that we are not going to deep aspects of the valves there. Valve, tricuspid valve, aortic valve, and mitral valve. So mostly the confusing part of this is tricuspid valve and mitral valve. People used to confuse with tricuspid valve location and mitral valve location. So first most important thing you should focus on is tricuspid valve is a right-sided valve. So this is a right-sided valve, and mitral valve is a left-sided valve. During questions, they used to confuse, or sometimes people forget which is right, which is left. So this should be there in your mind, that right-sided valve is tricuspid valve and left-sided valve is mitral valve. So these two are atrioventricular valves, AV valves. So which means AV valve are those which are between atria and ventricle. And the another one, right-sided valve, is pulmonary valve. So this one again is a right-sided valve, and aortic valve again a left-sided valve. So why do we focus on right and left is because questions MCQs used to be like right side or left side lesions. So right or left-sided lesions are the focus in questions usually. So right-sided valve and left-sided valves. So to sum up, we have right-sided valve as pulmonary valve, tricuspid valve, and left-sided valves are those aortic valve and mitral valve. Pulmonary valve is the valve which is located at the outlet of right ventricle. So right ventricular outlet that pumps blood to lungs for oxygenation. So that is one case. And mitral valve is the left-sided valve, and aortic valve again is the left-sided valve. So as we said, when pulmonary valve is the valve which is in the outlet of right ventricle, in the left ventricle at the outlet we have aortic valve. So this is the two outlet valves, and the other two, tricuspid valve and mitral valve, are those which are located between the atrioventricular areas, or atrioventricular valve it is called. So I think the concept is clear. Most of the children used to get confused with what happened with them is usually they will be confusing what is pulmonary valve, what is mitral valve, where is the location. This is the basic concept that people should know before approaching any questions. So that is the first one. I'm beginning with a little basic concepts, because maybe there a few people will be there like they don't know which valve is where, or sometimes they used to get confused with. Some people used to make some codes not to forget which valve is in which location. So right now, to sum up, I will say right-sided valves are pulmonary valve and tricuspid valve. whereas left-sided valves are aortic valve and mitral valve. So this is the crisp point that you should remember from the topic which we have discussed in this slide. So next, I will be coming to the most common causes of valvular heart diseases. So we have mostly 5 most common causes of valvular diseases. So one is age-related changes. Age-related changes means degenerative valve disease. Degenerative valve disease occurs as the age advances. There will be sclerosis of the valve causing age-related stenotic valvular disease. The another one is rheumatic fever. In rheumatic fever, usually it is by infection with group A streptococcus. So rheumatic fever causing rheumatic heart disease, and then that causes a valvular disease. The third one is infective endocarditis, an inflammation of the heart tissue caused by an infection in the bloodstream. So this you should focus on that. The infection is not directly to the heart. Maybe there will be a nidus for the infection, usually after any dental extraction or something, which who are prone for valvular diseases will get an infection through dental extraction. So this infection can cause a valve disease or a vegetations over the valve causing valvular diseases. The fourth one is heart attack, myocardial infarction or heart attack. So degenerative valve diseases can also be often associated with elderly people, but heart attack can cause acute onset lesions like mitral regurgitation. This is one which usually will be there following MI. This is because of the rupture of papillary muscles. So there will be a rupture of papillary muscle when there is ischemia to the papillary muscles. When this happens, there will be an acute onset of regurgitant murmur. This is a common finding following MI. And if the MI causes to the valve, so the wall of the heart is affected. Suppose wall of the heart is affected. MI causing wall of the heart will never cause an acute MI, but this causes dilatation of the ventricle or dilatation of the valve. So dilatation or dilation of the valve, that then causes a regurgitant murmur. So regurgitant murmur can be an acute onset. In this case it is acute. This is a chronic cause. So what chronic cause means, like the ischemia, where the ischemia is affected is the main important thing to focus here. The wall of the heart means we have blood supply to the wall of the heart, which goes infarction when there is an MI. So this can lead to dilatation of the left ventricle or right ventricle or whatever it is. This can cause regurgitant lesions, and if that is the case, this will be slow process. But if that is an acute case, it is due to directly affecting heart attack causing the rupture of papillary muscles. So I hope the concept is clear now. This is a concept where they usually ask for MCQ exams. So if it is acute MR, that is due to papillary muscle rupture following ischemia. If it is not acute, means subacute or slow process. Subacute. Not acute means subacute. If it is subacute, then the cause is usually wall ischemia. Please note down the point because this is important for MCQ exams. So the fourth one is heart attack, as we said. Now the last most important cause of valvular heart disease is birth defect. This is congenital defects. So there can be congenital valve disease which occurs before birth, and that is an abnormal formation of the HAAD valves during abnormal formation of the HAAD valves during embryonic stage. So this is the fifth cause. So to sum up, the important causes of valvular heart disease are age-related changes, rheumatic fever, infective endocarditis, heart attack or myocardial ischemia. I have given an important point here, that how to differentiate between a cause of MR. That MR can be due to rupture of papillary muscle if that is acute following an MI, or it can be due to a dilatation of left ventricle following regurgitation of the bloodstream. That is a slow process, and there the ischemia is for the wall at first. Now the last one is birth defect. These are the main important points you should remember discussing on the topics for the causes of valvular heart diseases. Now, when there is a damaged valve or deteriorated valve, this can cause two kinds of lesions. So we say lesion, that is a valvular defect. So this valvular defect can be two types. What are the two types? The first one is stenosis. That means constriction of the valve or narrowing of the opening of the valve. So these are stenosed valves. So stenosed valve can be due to age-related conditions where there is sclerosis, or it can be due to some other congenital anomalies. Whatever it is, stenosis is the constriction or narrowing of the valve. And regurgitation is the second type of the lesion. Incomplete closure of the valve leaflets, there results a backward flow of blood. So to make sure you understand it, I'll just add on here. That means usually when a valve is closed, it looks like this. So this is the way when a valve or a heart chamber is closed, it will be looking like this. That is, usually it is closed, but there is an incomplete closure. Incomplete closure means whenever there is a complete closure is tried, the valve is not closed, there is an opening defect. This causes regurgitation of the blood. So regurgitation means that there is a backward flow of the blood. Suppose I will just write a schematic diagram here. Suppose this is our heart, this is right atrium, this is right ventricle, this is left atrium, and this is left ventricle. So in this case, if there is a regurgitant lesion in the tricuspid valve, that means tricuspid regurgitation. So here is our tricuspid valve. So if there is a tricuspid regurgitation, that means there is a defect in the closure of tricuspid valve. This causes a backward flow of blood. So usually the blood should come like this way, but there will be a backward flow. And again, if there is a lesion in the left side of the valve, that is left side lesion, which is mitral valve usually causes a regurgitation from left ventricle to left atrium. So usually the blood comes from left atria to left ventricle. If there is a mitral valve regurgitation there, the blood goes back. So mitral valve, we have mitral stenosis, mitral regurgitation, and an exception is mitral prolapse. Mitral prolapse means mitral valve prolapse, MVP. So this is a congenital condition usually causing the prolapse of mitral valve. Now coming to the aortic valve. So aortic valve, we have either stenosis or either regurgitation again. So if it's coming to the tricuspid valve, we have again stenosis and regurgitation. The same thing for pulmonary valve, which we have stenosis and regurgitation. So coming to the topic, we have seen what are the types of valvular heart diseases and what causes the valvular heart diseases, which is stenosis and regurgitation. When coming to the stenosis, we have mitral stenosis, aortic stenosis, tricuspid stenosis, and pulmonary stenosis, and the same for regurgitation lesions. And the exception here we have is mitral valve prolapse. Here I would like to say this mitral valve prolapse is important for MCQ questions. That is why I've mentioned here this can be due to a congenital cause. So coming to classification of murmurs. So before, murmurs are caused by what causes murmur? This is by turbulent flow of blood across a defective valve or defect in septum, or can be due to turbulent flow with hemodynamic changes as flow murmurs. So we have a turbulent flow across a normal valve, may be due to a flow murmur, or there can be a defective valve or defect in the septum, that is atrioventricular septum, or like atrial septum and ventricular septum. So ASD and VSD are the two causes of ventricular septal defect and atrial septal defect. These are the septal defects usually come across. Right now we are dealing with systolic murmurs and diastolic murmurs as well as continuous murmurs. So this is another type of classification of time period of murmur is important. So here, time period of murmur, if it is systolic, that means during the contraction of ventricles, that is systolic, we say these are systolic murmurs, and we have diastolic murmurs, which is due to when there is relaxation of heart muscles. So systolic and diastolic. Again, continuous murmurs which are there throughout the systole and diastole. That means throughout the cardiac cycle, complete cardiac cycle completely it can be heard. That is continuous murmurs. So on auscultation, we can divide the murmurs as systolic, diastolic as well as continuous murmurs. So systolic murmurs are those murmurs which can be divided again as early systolic murmurs, mid-systolic murmurs, and pan-systolic murmurs. Pan-systolic murmurs means throughout the systole, and late systolic murmurs. So the murmurs which are classifiable as early systolic murmurs are those which is a murmur of MR. MR means, as I say, you should remember, MR is the lesion where there is a defect in the left side of the valve, left-sided lesion between atria and ventricle, causing a regurgitation. So this can occur early systole. Again, tricuspid regurgitation, the counterpart of MR, this again can cause early systole, and VSD, ventricular septal defect. If you note this, these three are the same lesions which you will get in pan-systolic murmurs. So throughout the lesion, throughout the cycle of systole, you get MR, TR and VSD. So here I will add one point, that is MR, TR and VSD are those which can be heard throughout the systole. That is called as pan-systolic. So pan-systolic. So that is the case. Now, mid-systolic murmurs are those murmurs which are best heard during the mid-cycle of the systole, that is mid-systole. These are flow murmurs first of all. Flow murmurs. Again, increase in flow rate across a normal semilunar valve. That is again a flow murmur. Then another one is aortic valve sclerosis. That is a mid-systolic murmur. That is aortic valve sclerosis or stenosis. Aortic outflow obstruction can cause mid-systolic murmur, and pulmonic outflow obstruction can cause again a mid-systolic murmur, and dilatation of aortic root or pulmonary artery. So these all, if you see, if you focus, these all are aortic pulmonary, which means you get aortic and pulmonary valves are outflow valves. So these are outflow valves. So during systole, the blood passes through this. So to murmur, this is a pan-systolic murmur. This is because the murmur valve, the valve between right atrium, between left atrium and left ventricle. Here we have the mitral valve. So from here we have a outflow tract. So this outflow tract goes as aorta. I will be explaining for mitral valve, but consider the same for the tricuspid valve. So mitral valve can get a mitral regurgitation when there is a systole. That is, the ventricles are contracting from all the sides. This pushes the blood from the left ventricle towards the aorta and through the aorta to systemic circulation. So here mitral valve defect, that means the mitral valve is not closed properly, means during the systole the pressure is not normally confined in the ventricle. It can push the blood outside since backwards, since the valve is not completely closed. So that causes a backward flow of blood. So here we have a backward flow of blood again. This is the reason for MR. The same applies for TR in the right side. So TR in the right side and MR in the left side. These two causes a regurgitation murmur when the systolic phase of heart pumps the blood out of the ventricles. So another one where you get a pansystolic murmur, as I said, pansystolic murmurs is MR, TR and VSD. So in the ventricular septal defect, that means here we have right ventricle, here we have left ventricle. There is a septal defect, which is a septal defect here. Usually when there is a septal defect, there will be mixing up of blood. So when there is a ventricular septal defect, then during systole, the both ventricles will be contracting. So this causes blood mixing up and also passing from left to right, mostly because the ventricular pressure is more in the left side, but there can be a minimal mixing from right to left also. So here this is a continuous process from the beginning of the systole till the end of the systole. Blood passes from right and left ventricles across from left to right. So this causes a pansystolic murmur in VSD. So these pansystolic murmur causes like MR, TR and VSD should be considered with concepts. Never try to forget this or never try to mug it up, because once you know the concept, you can make your own answers, and that will be enough for your MCQ exams. Because once you mug up, you have a great chance that you will forget what you have mugged up during the exam stress. So I'll say this is the case what we were discussing about systolic murmurs. Now I have discussed now early systolic murmurs, mid systolic murmurs, these are outflow murmurs, and pansystolic murmurs. Now again you will see this late systolic murmurs. Among that you have again the two causes of prolapse, mitral valve prolapse and tricuspid valve prolapse. So here you should note down the valve prolapse means mitral valve prolapse and tricuspid valve prolapse. These two causes a late systolic murmur. So late systolic murmur. So this was the sum up of systolic murmurs. Now Again, coming back to my topic for diastolic murmurs. So diastolic murmurs is the classification of murmurs. Once you have completed systolic murmurs, you can now note down what are diastolic murmurs. So diastolic murmurs are those murmurs which occur when the heart is relaxing. So here the heart is relaxing, so heart relaxes. So this can be early diastolic, mid diastolic and late diastolic again. So early diastolic are aortic regurgitation. So I'll go back. Okay, let me complete this. Aortic regurgitation, pulmonary regurgitation and left anterior descending artery stenosis. So I will consider these two as most important one, aortic regurgitation and pulmonary regurgitation. So why? As I have told you before, the aortic and pulmonary are outflow tracts. So this is aorta, pulmonary. During systole, we have a push forward for the blood passes towards the systemic circulation as well as the pulmonary circulation in the case of pulmonary valve. So if the valve is defect here, in the case of aorta, the valve defect can cause a backward flow of blood. Once the ventricles are here, ventricles are contracting during systole. So when the ventricles contract, the blood passes through the aorta forwards as for the systemic circulation. So the same way it happens for the pulmonary circulation again. So if the ventricles stop pumping blood, the backward flow of blood will happen to the ventricles through the defective aortic valve or through the defective pulmonary valve. This is because the valve is not closed completely, and this condition is called as aortic regurgitation and pulmonary regurgitation. So AR and PR. Hopefully we will be discussing each individual valvular defects, maybe aortic regurgitation, pulmonary regurgitation, aortic stenosis, everything separate. But now I try to conclude the most important concepts regarding the valves across the heart chambers and the murmurs that they cause, and the timing of the murmurs, the radiation of the murmurs, and how we can identify the questions from the MCQs. So that is the case. Now I have completed pulmonary regurgitation and aortic regurgitation. Now mid diastolic murmur. So this is early diastolic. So whenever the ventricles stop contracting, the blood starts coming backwards. That is aortic regurgitation and pulmonary regurgitation. Now mid diastolic murmurs are those murmurs which happens when during the mid diastole, that means during the cycle of mid diastole. So mitral stenosis is one case, tricuspid stenosis is another case, and Austin Flint murmur is the third important one across here. So stenotic vessels, suppose here we have a stenotic vessel. This is between right atria and right ventricle, that is tricuspid valve. So if the valve is stenosed here, there will be a backflow of flow of blood from right atria to right ventricle, which makes a noise during diastole. So you know when do the ventricles fill the blood? Here we have ventricle and atria. Ventricle fill the blood during diastole. So ventricle fill the blood during diastole. If there is a stenosed valve across here, the passive flow of blood as well as the atrial contraction pushing the blood towards the ventricle can cause a murmur here. This is called as diastolic murmur. This is mostly because mid diastole, because first of the diastole there will be a passive flow, and later there will be a forced flow of blood. This causes a mid-diastolic murmur. So this applies for which are murmurs? So mitral stenosis and tricuspid stenosis. Again, Austin-Flint murmur. Austin-Flint murmur. This is a murmur usually seen in the case of aortic regurgitation. So this is a case where aortic regurgitation, as you know, the blood passes forward during systole, and whenever the systole is completed, there is a regurgitation murmur, which is an early diastolic murmur, that is aortic regurgitation murmur, the backward flow of blood. This causes a diastolic murmur in the mitral leaflet. So mitral leaflet of atrioventricular valve between left-sided chamber, that is mitral valve leaflet causes a flutter or a vibration causing diastolic murmur. This is called as Austin-Flint murmur. Here, accordingly, we have a diastolic murmur with atria causing contraction in the diastole as the blood comes, and it causes a vibration of the mitral leaflets, as well as the backward flow of AR causes again. So here during diastole there is a passive filling causing the blood from here above, and AR causing a blood flow back, that causes like this. So there is a vibration causing Austin-Flint murmur. Now late diastolic murmurs are those murmurs which causes late diastolic phase of diastole. So this can also be called as pre-systolic. So the late diastolic are again MS, TS, and complete AV block and myxoma or other causes. So I hope the HAAD murmurs, systolic and diastolic murmurs are now completed, and it is clear now. Now we have a continuous murmur. Continuous murmurs are those murmurs which is there throughout diastole and systole. This happens due to patent ductus arteriosus like PDA, which is a machinery murmur, and aortopulmonary window. Also in the shunts and AV fistulas. So shunt and AV fistulas, you get a continuous murmur. You usually get this in CKD patients, where these patients are kept on AV fistulas. And coarctation of aorta is another cause of continuous murmurs. So I think as now you understand the concepts behind all these murmurs, because mugging up all these murmurs is difficult. So that is why I stressed too much on why the murmur happens early systole, why it is mid systole, why it is pan systole and all. Hopefully I hope it is clear now. Now coming to the next topic, that is you have to see what happens, the intensity of murmur with inspiration as well as expiration. So intensity of murmur with inspiration and expiration is an MCQ question. So here we have a tablet capsule, that means right-sided lesion. This is why I focused mostly on right-sided and left-sided lesions in the beginning. So right-sided lesion, that is tricuspid and pulmonary valve, increase in intensity or loudness. That means increase in intensity means the murmur is becoming more worse and it is louder with inspiration. And this is because inspiration will increase venous return in the right side. So due to inspiration we have an increased venous return. This causes right-sided lesions more intense. In the same way, left-sided lesion increase intensity with expiration. This is because expiration will squeeze blood out of lung and into the left side of the heart. that expiration will increase venous return to left side of the heart. So this is the case. Here we have an exception, that is MVP and HOCM. So except MVP and HOCM, this is the most important finding you should be remembering throughout. So that is MVP and HOCM. So MVP and HOCM are those murmurs which are against the rule. So left-sided murmurs or left-sided lesions, mitral and aortic, increase with expiration, and right-sided lesions, whatever it is, will increase in intensity or loudness with inspiration. So the concept here is more blood wherever it is. This is the most important final capsule. More blood increases all murmurs except MVP and HOCM. So if there is more blood in the chamber of the heart, or more blood is passing through the defective valve or the defect, that causes more blood, causes increased murmur. So increased murmur except MVP and HOCM. If you know this is over. So that is more blood increases intensity except MVP and HOCM. HOCM is the murmur of hypertrophic obstructive cardiomyopathy. So we will be coming in detail to these two, but to be at the moment, you just examine, you just focus on this capsule. That is, more blood increases all murmurs except MVP and HOCM, and less blood decreases all murmurs except MVP and HOCM. So more blood increases and less blood decreases all except MVP and HOCM. So in the case of MVP and HOCM, you will come to know here MVP and HOCM decreases with more blood, and MVP and HOCM increases with less blood. So if there is a less blood in the chamber, the intensity of MVP and HOCM is increased. So here, just my point is, just focus on only one of the capsule. All you can forget right now. Forget means just the concept. I'm coming back. So here, if you know among these 4 points, if you know the basic concept of inspiration increases venous return to right side, expiration increases venous return to left side, and this point, more blood increases all murmurs except MVP and HOCM. So if you know this, you can answer any question. That means more blood, when it happens, more blood to all murmurs, whatever you can auscultate by, either it can be left or right, no matter, it increases with respiration, means it is inspiration causing more blood. So that lesion would be a right-sided. If it is increasing by expiration, then the lesion would be a left-sided lesion, because expiration is the one which increases blood in left side of heart. So this is just the opposite of first point. Now what happens is, murmurs worsen when it becomes more intense. So whenever a question says the murmur worsen with inspiration or murmur worsen with expiration, which means it is more intense. So more intense is equal to worsen of the murmur. Murmur worsens. Now I'll be going a little faster because this is over. Right now the concept is over to diagnose whatever case you get. Now we'll just move on. The other 2 points is standing and Valsalva. Standing causes suddenly from a squatting position, open the venous capacitance of the legs, that causes decreasing venous return to the heart. So standing causes decreased venous return, and Valsalva is the one which exhalation against closed glottis. These two will decrease venous return. So standing and Valsalva is one set. Standing or Valsalva causes decreased venous return to heart. Again, this is similar to the use of a diuretic, means that there is a less blood coming to the heart. Now, squatting and leg raising. Squatting means sitting, and leg raising, you are lifting your legs. This causes increased venous return and results in more blood. If you know this standing and Valsalva as well as squatting or leg raising, standing and Valsalva causes decreased blood. Here it is more blood. Now, if you go back, here we have our capsule. More blood increases all murmurs, and less blood decreases all murmurs except MVP and HOCM. So, what causes more blood? Standing and Valsalva will cause less blood. So, standing and Valsalva, less blood. And what causes more blood is sitting or squatting. And squatting and here squatting and leg raising, these are the one which causes more blood, increased venous return. So stenotic and regurgitant murmurs are always treated with diuretics, and salt restriction, because less blood we make, it will be improved. But in the case of MVP and HOCM, this worsen their cardiac physiology. So always note that the diuretic use in MVP and HOCM should be very cautious, because the diuretics in these two cases can cause worsening of regurgitation of MVP and obstruction of HOCM. So HOCM is hypertrophic obstructive cardiomyopathy, which is a separate topic which we will be coming or we will be discussing in future. But worsening this regurgitant lesion of MVP and obstruction of HOCM happens. So again I say MVP and HOCM are exceptions. If you know this and you know the capsule, you know everything. You can make your own answers. If the MCQ asks what happens with inspiration, what happens with inspiration, what happens with expiration, and what happens with Valsalva, what happens with standing, what happens with squatting, what happens with leg raising, and with the timing of murmur heard, like it can be either systolic, diastolic, or continuous. If you know this much, you can answer almost all murmur questions in the exam for prometric mainly and other exams, because if you forget, you can make your concepts from your basic thing which you have learned right now. So just don't forget again. This is the case where we discuss all the causes of murmurs and the murmur timing, murmur effect with inspiration, expiration, Valsalva, standing, squatting, leg raising and all. Now we have two more things which is called as, so this box is just summing up like what happens with squatting and Valsalva for mitral and aortic, mitral valve and HOCM, which I don't want to discuss because you can make your own answers. For example, if suppose squatting, what causes it for mitral regurgitation? So squatting, I will think from squatting will cause increased venous return. This causes more blood. So my capsule is more blood increases all except HOCM, which means MR murmur will be increased in intensity, which means it worsens. So squatting increases venous return, which causes more blood, that causes increased venous return, causing more blood in the chamber, causing MR intensity to increase, that is MR is worsened. So here you can see mitral and aortic stenosis, it is increasing. Mitral and aortic regurgitation, it increases. So likewise you can make whatever it is. So suppose if the case is squatting, instead of squatting, if they say leg raising, or suppose we can say okay, leg raising or squatting, effect on MVP, so mitral valve prolapse. So here squatting and leg raising causes increased blood causes increased blood in the chamber, which means more blood increases intensity except MVP and HOCM. So MVP, it is exceptional case, so increases intensity. Here it will decrease intensity. Decrease intensity means murmur is better, not worsened. Murmur is better. And the same thing happens for HOCM. Okay, now instead of squatting and leg raising, if suppose you have Valsalva, and you have standing. So standing or Valsalva, it causes decreased blood in the chamber. Because of the decreased blood, there is less blood. What happens with the less blood? So more blood causes increased intensity, but except MVP and HOCM. This is our capsule. So less blood will cause decreased intensity in all the murmurs except MVP and HOCM. So in the case of MVP, there will be an increased intensity. So that is the exception of MVP. So MVP and HOCM is an exception. Again, I will remind this, MVP and HOCM. So you can make by hearting all the topics, and by hearting the tabular column will be difficult. So you can make your own. That is what I say. This is the case where you can make all your things with the capsules I have told right now. So just don't forget to note down this, because this is an important thing which will help you confidently to appear for all the exams which discuss the murmur questions. So murmur, what happens with this murmur, what happened with that murmur, with this, with that, with standing, with Valsalva. This is a common question, so just make a note of this. Okay, now the last one in this capsule I will say is the effect of which we have told right now in a tabular column. So here, aortic stenosis, pulmonary stenosis. This is actually stenosis murmur. These are regurgitant murmur. These are again stenosis murmur, and this is VSD, and this is AR, PR. So if you make a set like this, AS and PS are systolic, as I said. Mitral MR and TR again systolic, because I said this is pan systolic. So here mid systolic means it is a crescendo decrescendo, which means increases in intensity and it coming to a peak and then start decreasing in intensity. So AS and PS is same, like this is a crescendo decrescendo. Now MR and TR are, as we said, these are MR, TR are pan systolic. So we have throughout the cycle systole, it is pan systolic or hollow systolic. MS and TS, so I have told MS and TS are those lesions which are diastolic. So diastolic means there is an initial increase in the sound which later decreases, and when the atria start contracting, the murmurs again increased. So it is a kind of lesion like here. The sound will be initially it will be very high, then it comes down as the blood volume is low, but in the mid of the cycle of diastole, then the atria contracts and then again the intensity increases. So the pattern will be like this. So tricuspid stenosis. VSD, as I told earlier, VSD is a pan-systolic murmur. So MR, pan-systolic are those MR, TR and VSD. So VSD again is an exception, that is pansystolic. Now AR and PR, these are diastolic murmurs, which are early diastolic murmurs. So these diastolic murmurs are the backflow of blood when there is systole is end. So when the systole ends, the diastolic, because more blood will be there initially, which then decreases slowly. So this is a decrescendo pattern. This is holosystolic. Again the same is pulmonic regurgitation. Again this is the same pattern of aortic regurgitation. So pulmonary and aortic regurgitation have the common pattern. So I will just sum up again. Aortic stenosis is crescendo decrescendo, pulmonary stenosis again crescendo crescendo, mitral regurgitation is holosystolic, and tricuspid regurgitation is again holosystolic. Mitral stenosis and tricuspid stenosis is again increases in sound as the end of this is due to towards the end it increases because it is due to atrial contraction. So ventricular septal defect is again an exception for pansystolic continuous murmur, which is VSD. Then there is a left to right shunt, as I told you, left to right shunt will be there. Now aortic regurgitation and pulmonary regurgitation, again it is decrescendo pattern. So these all are MCQ bound questions, MCQ important, because they can ask you one patient this that come with old history of such and such things, which shows on examination there is a crescendo decrescendo murmur which is mid systolic, like that. So to complete this box, I will also add the auscultation site best heard at aortic. Pulmonary is best heard in the aortic area, that is aortic is heard in the right second intercostal space. So you know, right, aortic area is different, that is right second intercostal space. Pulmonary area is the left second intercostal space. Mitral is best heard in apex, and tricuspid is fourth intercostal space, left sternal border. Mitral stenosis is heard in the apical region again. So this is mitral area, apical is mitral, and tricuspid is fourth intercostal tricuspid area. So this is again lower sternal border. VSD is heard in third, fourth, fifth intercostal space and left side, left sternal border. Now aortic regurgitation is in the third intercostal space, and both pulmonary regurgitation is in the third intercostal space. So these two behave like same, and mitral stenosis and tricuspid stenosis behave like same, and this is a separate entity in this box, and aortic regurgitation and pulmonary regurgitation behave like same. So this is the sum up of the all murmurs and their cardiac cycle timing, auscultation site, configuration of the sound, how the configuration sound is, and continuity of the murmur. Now we'll again come up with a quality pitch radiation of the murmurs. The respiration change in this box I will quit, because we have already dealt with this with our capsule formula. So this is not important for us because we can make our own. This is difficult to just remember always. So that is why I approach the murmurs in this pattern. So this is a different approach to see murmurs. So aortic C, again we have the set, similarly behaving sets. Okay. Quality. Aortic stenosis, both are usually harsh and coarse, maybe pitch is medium. Now aortic stenosis, the radiation will be into the neck and carotid, and pulmonary stenosis is the left upper neck and shoulder areas. Okay. Now mitral regurgitation and tricuspid regurgitation, this is a blowing character murmurs, and which have a high pitch, both are behaving same, and one is radiating towards, that is mitral regurgitation will radiate towards left axilla, left sternal border and all, but tricuspid regurgitation radiate to left sternal border and not towards the axilla. Okay. Now mitral stenosis and tricuspid stenosis, these all are both rumbling sounds, which are low, best heard with the bell. So these are low and best heard with the bell. So the question is, which of the murmurs are best heard with the bell of a stethoscope? So that is mitral stenosis. So MS and TS, best heard maybe with the bell of stethoscope. Okay. Now, radiation is very rare in this case. Now, ventricular septal defect is a harsh murmur, high-pitched, may radiate across the precordium everywhere, but not in the axilla. This is never in the axilla, but other areas it can be. Aortic regurgitation is a blowing murmur. Again, pulmonary regurgitation is again a blowing murmur. Best heard with the diaphragm. High-pitched. Both are high-pitched and may radiate to second intercostal space, right sternal border, and may proceed to apex. Now, the changes with expiration or inspiration, which may intensify or decrease its intensity, which is very difficult to remember, as it is very difficult. So I will follow my capsule which I have told you. So this is quality pitch radiation of the murmur. So if you remember these kind of things, it is very easy now to approach a question of valvular defects and murmurs. Okay, now coming to murmur of MVP. MVP murmur is a late systolic murmur which is crescendo murmur. This is two exceptions. One is MVP, other one is HOCM. We will be discussing the murmurs of MVP and HOCM. So MVP murmur is a mid-systolic murmur which is best heard at the apex, but it begins after a mid-systolic click. So if this is the murmur, it is a crescendo murmur. It will be increasing its intensity and it is followed after a mid-systolic click. This is called as what we call as the murmur of MVP. This mid-systolic click can either be late systolic murmur also. So this makes a mid-systolic click followed by a murmur causes this murmur to be a late systolic murmur. So mid-systolic click followed by a late systolic murmur is the case of MVP. In MVP, the symptoms of congestive heart failure are usually absent. Most often it is atypical chest pain, palpitation and panic attacks. Beta blockers are the treatment of choice. Now, the last one is HOCM, murmur of HOCM. This is again an important question in MCQs because these two are exceptions. Wherever there is an exception, there is a chance of MCQs. So MVP and HOCM. This is best heard in the left sternal border. So left sternal border is the best heard place and they do not radiate into the carotids. So hypertrophic cardiomyopathy is like hypertrophic obstructive cardiomyopathy is a crescendo decrescendo murmur which is like this, and its effect on squatting and standing decreases blood, causes worse intense because less blood increases MVP and HOCM, which means more blood increases all murmurs except MVP and HOCM. Now squatting is a case where you have increased blood flow to the heart, so there is a more blood. So more blood coming to the heart means more blood increases all murmurs except MVP and HOCM. That is our capsule again. So more blood which will increase all other murmurs, but it will decrease MVP and HOCM. So there is a decreased, less intense murmur. So this is the thing. Now you would have seen here one case called hand grip. This is a special test, and another one is amyl nitrate test and hand grip test. This I will discuss right now. So hand grip maneuvers and amyl nitrate test are a special test. So here hand grip maneuvers are done when the patient squeeze examiner's hand. So you give your hand to patient if you are examining the patient. So patient squeezes the hand of examiner. This causes contraction of muscles of arm and this compress the arteries of upper extremity, that is brachial, radial and ulnar arteries. This increases afterload because there is a compression. This increased afterload and this causes a decreased ejection fraction by obstructing the ability of blood to empty the heart. So there is an increased afterload, that is due to the compression, and there is a decreased ejection fraction due to the obstruction or compression. So this causes, hence hand grip causes decreased AS murmur, because AS is an outlet murmur, aortic stenosis murmur, that is due to decreased ejection fraction. It increases murmur of AR and MR because AR and MR are due to increased afterload, more blood. So increased afterload means there is a presence of more blood in the heart chambers after asystole. So more blood. So what will happen if there is a more blood? As we know, our capsule again, more blood causes increased intensity of all murmurs except MVP and HOCM. So MR and AR will cause increased afterload, will have a more blood. This increases MR and AR. Decreases AS means there is a decreased ejection fraction due to compression. Now it will decrease MVP and HOCM. Why? Because again there is more blood. So more blood due to increased afterload causing decreased MVP and HOCM. So that is why I told you our capsule is more important. Okay. Now amyl nitrate. That is another test. Amyl nitrate, a direct arteriolar vasodilator, increases forward flow of blood. So this amyl nitrate is a case which increases forward flow of blood and decreases regurgitation, act like AC inhibitor or ARBs. So this increases ventricular emptying. So this increases ventricular emptying means if you use amyl nitrate, there is a less blood in the chamber. So decreases all murmurs except MVP and HOCM, which will be increased because more blood increases all murmurs except HOCM and MVP. So less blood means it will decrease all murmurs, but except MVP and HOCM it will increase. So this is due to less blood. So here amyl nitrate causes less blood in the heart chambers. So amyl nitrate causes less blood, and hand grip causes more blood due to increased afterload. Why it is increased afterload? Because of the compression of arteries causing reduced ejection fraction. So this is the case of hand grip and amyl nitrate. So these are the other questions which will be asking in MCQs, like what will happen for MVP murmur with amyl nitrate, or what will happen for MVP murmur with hand grip maneuver. So this will be thorough with. This is easy. I have discussed the concept why it is causing. So if you know this, you can answer. So once you revise all the topics which I have told or covered right now, it is easy that you can tackle any questions of murmur related topics, like your murmur related valvular diseases. What is the murmur causing each pathology causing what murmur, what is the timing, what happens when there is increase inspiration, expiration, squatting, standing, everything. Now HOCM, hand grip murmur, hand grip causes less intense because hand grip causes increased afterload. There is more blood causes less intense, and this ends the conceptual approach of murmurs, which is a different approach. Usually people go for an approach where they will be going from the individual murmur like AS, then they will go for MR, MS, individually studying all the murmurs, causing all confusing data, and they will be discussing pathology, etiology, everything. What is the murmur, what is the timing, what is the cause of this, everything I will be discussing. But once you come to the exam, you will mix up all the problems. So I have made a different approach where you can analyze all the murmurs in a way that it will help you to tackle your MCQ exam. Usually these questions are seen in DHA, HAAD for Abu Dhabi and Dubai exams, also for Saudi prometric exams, and you can also see it in MRCP kind of exams, because these are high yield topics where people used to confuse, and they will have some issues with tackling these problems. So I hope it is completed right now. So we have discussed all the topics. I have told about every now and functional anatomy of the valves and valvular diseases. I have told about the causes, what are the types, timing like systolic murmur, diastolic murmur and continuous murmurs. I have told about our capsule, which is very important of this session, and I have told about the effects of each murmur with their effect on what happened with inspiration, expiration, everything, squatting, standing, leg raising. I have discussed 2 boxes. These are the 2 boxes which I have discussed. This is one classification of murmurs accordingly with the auscultation site, cardiac timing and configuration of the sound. The other box is this one, which is showing you pitch, quality, radiation and changes with respiration, which is not a big deal for us. Now MVP murmur and HOCM murmur. So these are the main murmurs which we have discussed, and this covers all the murmurs in cardiology. And again, in the last we have discussed hand grip maneuvers and amyl nitrate. So this completes all the MCQ related as well as clinical knowledge on murmurs. So now on, you will be approaching murmurs in a systematic way, which will be helpful for you to diagnose clinically as well as to tackle MCQ. So I hope the session was good. It is a little lengthy, I know, but I took a little time because the concepts should be clear. So thank you for watching. We'll see with another topic, mostly with a question discussion, or maybe a different topic sooner. Okay, thank you.